but our students and other people within the country have joined, and it will be around 300 people or little more than that. So that is it.
And I am planning for about an hour. Is that?
Yeah, that will be fine. No problem.
And maybe have some question and answer.
Yeah. That is no problem. Because there is no other program, of course, and unless you are feeling sleepy, we can go ahead. That is no problem.
No, it's.
Yeah. Mrs. Sanjana, shall we start? Mrs. Sanjana?
Yes, sir.
We will start.
Yes, sir. Yes, sir.
Yeah. I officially welcome Dr. Samyukta Jaiswal. I thank her for accepting our invitation to take part in this webinar. I welcome you. Yeah. Over to Mrs. Sanjana.
Thank you, sir. Mrs. Sanjana, can I begin, or it's asking if I should begin to share my screen?
She is going to introduce you to the audience, tell about you and your work. So then we can start.
Sure.
Mrs. Sanjana?
Yes, sir.
Yeah, please start.
Yes, sir. Yes. Just a second. Just a second, sir. There is a few network issues. Just a second. Just a moment. Very good morning to one and all. Am I audible to all? A very good morning to one and all. I welcome you all to the 7th session of the webinar. We have with us today Dr. Sanyukta Jaiswal as the resource person for the current session. Dr. Sanyukta Jaiswal is an associate professor in the speech language pathology program of Department of Hearing, Speech and Language Sciences at Gallaudet University. She completed her BSc as well as MSc in Speech and Hearing from All India Institute of Speech and Hearing, Mysore. She received her PhD from the University of Iowa in the area of physiology of voicing control during speech production. She directs the Voice and Speech Physiology Research Lab, which focuses on acoustic and physiological analysis of speech production with an emphasis on the role of sensory feedback in its control and regulation. She is also interested in voice and resonance management in oral rehabilitation for deaf and hard of hearing population. With this note, I welcome you, ma'am, to the current session, and I request you to kindly take over the session.
Thank you so much, Ms. Sanjana. Let me just check if everyone can hear me okay. Just give me a heads up if my voice is okay and clear.
Yes, you are audible.
Sure. I will begin my lecture and start sharing the slides in just a second.
Yes,
but I just wanted to make sure that my voice is audible and if it's also understandable. Over the years, it's been 22 years since I have been in the US, and my accent has taken a form that is neither Indian nor American. So it's somewhere in middle. And so if I am not understandable, if some word is not clear, please feel free to stop me and ask to repeat. And I'll try my best to make sure that it is both audible as well as understandable. So today, I am really privileged to be a part of this honorable event that is being undertaken by the JSS Institute, and also wanted to wish a very hearty congratulations on its 50th year of completion and celebration of that. It also is a very personal, along with a professional honor, to be a part of this event, because I see that the lineup of panelists actually have included a lot of my own professors during my undergrad and graduate studies. So it is indeed an honor to be a part of a panel that has included my gurus. I also am very thankful to Dr. Nataraja for inviting me to this panel, as well as for making sure that all the logistics for that were in place so that I could be here with all of you this morning. It's morning for you. It's little past midnight for me here. So if my voice sounds a little weak or tired, please feel free to diagnose me and offer your own analyses of what could be possibly wrong. With that, I thank Ms. Sanjana also for the very nice introduction, but I would like to tell briefly a little bit about my own journey in the realm of voice. So I have, as the introduction mentioned, my current role is that of a faculty in the Department of Hearing, Speech and Language Sciences in Gallaudet University. What a lot of people may not know is Gallaudet University is one of its kind in the world, because it is the only liberal arts university that caters to deaf and hard of hearing. And the primary languages in the campus are both American Sign Language and English. So it's a very regular Department of Communication Sciences and Disorder in a very unique setting. And in that setting, we get to see a lot more of the voice use or different forms of voice use that also generate a lot of questions, research questions, as well as academic questions of her laryngeal mechanisms. A little bit about my own past prior to that is I have worked during my doctoral studies and beyond in different aspects of laryngeal physiology, and have had the honor to not only be in the not only look at the laryngeal system at the final outcome level, or this is the system, this is the behavior, this is what's happening to the voice, but also very minutely at the cellular, at the tissue level, as well as the tissue muscular level, as well as some research in interspecies vocalization and how it compares to human vocalization. So some of the things that I will be talking about today are also coming from actually having worked or having done research over the years in some of these areas as well. So I will begin by sharing my screen. And hoping everyone can see me. Largo ಕಾಣಿಸ್ತಾ ಇದ್ದೀರಾ?
Yes, ma'am. These slides are visible.
Yeah.
Okay.
Yeah, it is projected. completely. Yeah.
Yes. So, so the topic for today's talk is where are we now? And recent advances in voice disorders, both in terms of assessment as well as management. Now, I will start with a certain caveat, which is that over the years, voice has been one of the disorder areas in our field that has seen very diverse level of both analysis as well as advancements. So it is when I took up this topic, I was forced to look at things in a very generic way, because each topic, each subtopic within what I'm going to talk about today could be its own talk. So I thought it would be best to sort of keep it a broad overview, and provide certain specifics in a way that may be understandable to this broad audience that we have today. But if you have any questions or if you want to go deeper into a certain area, I'm very willing to have conversations or have a discussion beyond the talk. So um, this is the basic or the general framework of what I have in mind today. We will look at the assessment and management of voice disorders and the recent advances within 4 major domains. We'll look at what has changed or what has changed, advanced in terms of our own understanding of the basic anatomy, physiology, neurophysiology, the biomechanics of vocal fold or laryngeal system. I will also address a little bit of the technological advances. Again, some of the major ones that are upcoming or are becoming more and more prominent, even though with the caveat that it's so vast and so detailed, some aspects that it will take its own presentation. We will also look overall of certain changes that have happened in protocols or how they have been modified in recent years, with a couple of omissions in my presentation today, but I'll allude to what those omissions are as well. And also looking at some more newfound both ideas in how we do patient management or assessment, as well as treatment. You all may already be aware or informed about different treatment techniques and methods to work with patients. I will focus on some recent thinking behind these treatments or principles behind these treatments that are becoming more prominent and are guiding our current clinical practice. So with this as a framework to orient ourselves in the journey for the next 30 or 40 minutes, let's dive deep, as we say, or let's go further into what different aspects are. So the first thing I chose to sort of highlight was the advancements or advances that have been made in the basic sciences or understanding of the histological cellular organization of the vocal folds. And also why these are important or why they have become important enough as a new line of treatment. So a little bit about that. When I started my doctoral journey, which was almost 20 years ago, I had the good fortune to work with Dr. Stephen Gray, who had just recently published his paper in the 90s about the new layered structure of the vocal folds. So it was all very novel. Even the fact that our vocal folds are not one cohesive structure, but have these layers, and also documenting what these histological layers are and what they constitute, what kind of different cells make up those layers. And I still remember what was the most fascinating part, and I say this to my students all the time, is that the vocal folds were supposed to be, biologically, they were supposed to be just part of a valve system. They were not biologically, evolutionarily designed for voice and speech. They were designed to be a valve that protected the airway, and which was open during breathing and closed during swallowing or eating. There was some evolutionary behavior that was superimposed on that laryngeal system that included emotional vocalization. So if we look at the animal systems or even humans, we find that you could get the same animal could have like for example, a cat could have a hiss, could have a purr, could have a different form of vocalization to indicate that it was hungry or tired or distressed, or alarm calls. And so somehow these emotional information was superimposed on the vocal folds or the laryngeal function. And then on top of it, then we added our own speech and singing and professional speech, professional singing that involved a very fine level of control over these systems. And so that was attributed to this extreme high degree of neurological control that now was part of the system. And so even if you look at it evolutionarily, how our behaviors, how our vocalization behavior, even within an individual changes, how we use, depending on the task, we see some of those remnants of that evolutionary change as well. So coming back to this, why am I talking about cellular and histological organization, and how is that something that happened in early aughts related to 2021? Two main reasons. One is that we are beginning to understand more and more how that layered structure, the histological layering, is so important for absorption or management of stress. And here we are talking of two types of stresses. One is vibrational stress, which is more of an impact stress. And here examples of that would be loud talking or prolonged talking or a hard glottal attack that results in increased impact stress. And the other stress is related to the longitudinal strain along the length of the vocal folds that is related to pitch changes. And so what are the mechanisms or biological adaptations that allow for these prolonged elongation or quick elongation or continuous elongation or a very high degree of vibrational stress in a given time? And it goes back to the cellular and histological organization. So it has found, in terms of management, it has found not only is it it's a basic science curiosity that we're answering through these research questions, but also that they have found their place in understanding what aspects, how can we promote tissue healing and repair? How can we provide treatment that is not just behavioral, but also can directly target changes? So if there is a reduction in a certain protein, is it possible that we can inject that particular protein to prevent voice disorders from happening, especially phonotraumatic voice disorders? Is it possible that we can speed up the repair or healing by applying some types of growth factors or tissue healing factors that would create repair or that would allow for repair without scarring that can which is a different kind of fibrous protein or a fibrous connective tissue, which has more stiffness and alters the vocal output considerably. So that is the basic idea of why some of these techniques have found to we have seen advances in how we know how the system operates. So the mechanobiology, the mechanical stresses or the mechanical behavior of this vocal fold tissue has been considerably researched in the last couple of decades, but has been found that we're reaching closer and closer to finding treatment techniques that would allow for what's called proteomics or genomics, where the genetic makeup or the protein makeup of the tissue can be targeted for therapy, both as a rehabilitation measure and as well as preventative measure. So I'm going to kind of very broadly sort of talk about some of the ways that we have known this and the techniques, how they have come about. So there has been research done at molecular level, cellular level, histological level, as well as the overall buildup or at the organ level. And in terms of these systems, at the molecular level, we're interested in what kinds of proteins are made and where they're located. And I will sort of allude to my own research in this area where we had created what is called a bioreactor, where we were interested in what is happening to these vocal folds. Why is there a layered structure? And what makes that layered structure happen? And I remember how exciting that it was when I had and I say I because as a doctoral student, these are some things that I have done it in person, hands-on, is to extract the fibroblast cells from the vocal folds that were instrumental, that we thought that they were instrumental in creating these different proteins, and to extract them and maintain them outside the body. And so not only now that you had these cells, but you had to grow them outside the body. So now we were going in this whole domain of tissue engineering, which is very different cry from communication sciences and disorders. And then these cells, once they had we would put them in these scaffold material, allow them to grow for some time. And once they were ready, then we would place them in a bioreactor and expose them to different vibrational forces. And so you could have intervals, long periods of how long they are being exposed to vibration, what is the nature of the force, what frequency of vibration they're being exposed to. And then you would see what kind of proteins do they produce. And then not only what kind of proteins, but how are these proteins layered or how are they structured. And it has become more and more important now to create these bioreactors outside the body to simulate the laryngeal function and look at what these changes bring to the histological and molecular and cellular level, at the cellular, molecular, and histological level. It's very, very cool research. And when we understand that, we're able to kind of understand a little bit more about the pathways, the metabolic pathways, the pathways for repair, and also how materials transport across cells. So for example, for hydration, I still remember we used to talk like 8 glasses of water a day, you stay hydrated without ever really understanding what was the mechanism of hydration. When I'm drinking water, it's not really going to my vocal tissue. It's going to my, through the pharynx into my esophagus. So what does hydration really mean? Is it at the cellular level? Is it at the tissue level? Or is it systemic hydration that's important? What's happening? So how does it help if I just take a sip of water right before I'm talking? How is that hydration helping? So looking at how molecules of water or chemical toxins or even medicines transport through these cells have been important components of research. There has been also research across not just human models, but across rabbit models, mice models, other species as well, to look at what exposure to stress, different kinds of stress, vibrational, elongational, how does that impact the structural integrity of this tissue. There are also models that look at force changes, that look at what is happening structurally, mechanically, using different techniques that are also that may include microscopy or devices that help test the strain or look at tissue level changes. So these are all rather newish. I wouldn't say newish, but these are also areas that are being further explored, because we're not too far away where not only would you give some voice therapy exercises, but you may also be providing some actual histological or genetic counseling or information or some treatment aspect. We are also looking at the organ level. We're looking at computational models. FEM is finite element model. We break down each function into smaller elements or smaller parts to that structure and see if the muscle, if the TA muscle was contracting this much, what will it do to the edge of the vocal fold? What will it do to the middle of the vocal fold? How will the shape change? And so some of these changes, we cannot look at it within a person, but if we use those models, it helps us understand how those muscular activations and degrees of muscular activation or co-contraction of muscular activation, how will that impact the overall physiology, whether it be posturing, adduction, abduction, or vocal fold vibration, or elongation for pitch change, elongation or shortening for pitch changes. So very, very important research. And like I said, I'm willing to talk more if this interests you, but this was extremely fascinating and an aspect of research or a aspect of voice that we don't talk a lot in our regular conversations about voice. Okay, so the next overview of something that I wanted to take up was technological advances. Now, this is a rabbit hole. If I started like digging through, every bit of technological advance that has happened in even the last 2 years, we'll see that so many new technologies, so many quantal changes have happened. How we assess, the equipment we use for assessment, the algorithms that we use in assessment. And so it's we can spend an entire evening talking about it. But I am going to focus on two main aspects. The first one is the use of apps. And the second part is other types of devices that help that can be with a person and monitor the vocal fold usage, both as a monitoring device as well as a feedback device that can provide information to the client or the patient when they're exceeding a certain level or when they're not reaching the optimum level. So if you do, or if you have looked into our smartphone apps, some very basic apps are include some kind of extraction of frequency or intensity and provide feedback to the client when their frequency is at a certain level of voice. So it's doing this quick vocal analysis for frequency, so some spectral analysis. Same way for intensity. And intensity has been found to be extremely crucial also for patients, for example, patients with Parkinson's who have historically reduced loudness or reduced loudness range, and having that feedback of when they do not achieve the optimal loudness, getting that instant feedback of, and you know, you have simple we have dB meters and we have intensity meters of all types, and so it was not a very big stretch to have something for voice. And so there you will find, and I think they're all different areas of the world have different technologies available, but you will find there's a whole list of smartphone apps that can be used for vocal rehabilitation. And again, I am happy to direct you to certain literature that sort of documents what kind of apps can be used for different types of patients. So this is an example of a fairly recent publication. This is a lab in Boston, and they have been working quite extensively, actually, with, this is Dr. Hillman's group, and with ambulatory and ambulatory accelerometer-based monitors. So ambulatory means that the patient or the person can be walking around with them. It's something that's portable, and it's non-invasive. So it's not interfering or they can carry on their regular work life or personal life. And so the basic technological principle is to have a small accelerometer on the vocal fold or close to the vocal fold in the near the thyroid lamina, and it tracks the vocal fold movement or the acceleration of the vocal fold movement during the vibration, and extracts based on that how long someone has been voicing and how intense, what the intensity of that voicing has been. And so this forms the basic principle or basic framework, which is then there are different apps that may pick up that information and provide user-friendly feedback to the patient. And here is the reason why I picked up this particular article to spotlight, is that it's not just that you're giving a visual feedback that helps the patient or client monitor what they're doing, but this type of feedback, what kind of feedback is helpful? What kind of feedback reinforces behavior? When should the feedback be given, and how easy it should be to monitor a certain behavior? So it also includes within it motor learning principles. So this sort of integration of not just that you have the technological device and know-how and you have a user-friendly portal, but also that the nature of the feedback is based on the principles of learning, especially the motor learning. So I have provided, and this hooks on to the smartwatch or a smartphone. And so it's easy to sort of monitor and have it, have the patient wearing without disruption in the daily activities. Also, it provides reinforcement when they have achieved the task that was required, and it does not takes away a little bit of the shame when it's not. So when should reinforcement be given, and the nature of the reinforcement that will promote certain behavior. In the technological advances, another thing that's kind of fairly cool, and we're seeing more and more within our scope of practice, is the fact that artificial intelligence and machine learning is finding a big place in how we both classify voice disorders, identify voice disorders, and perhaps may even also from a teaching perspective, my students always talk about how we don't have anchor. How do I know what's breathy? When I'm filling up KP forms, I am not sure, as a beginning clinician, I'm not sure how should it sound like. What is a 0 on the scale? What is 50 on that scale? What is 100 on the scale? And so if we had to create voices that would mimic or simulate those individually, when I say individually, means exclusively, just vary the breathiness, just vary the strain, just vary the roughness, which is not possible as much when you're looking at a pathological system or model in a person, but outside the body, it can possibly be through machine learning or through algorithms. Specific parameters can be changed, both as serving as models, training models as well. On the other hand, and this is actually a link, so if you're interested now, I'm happy to share this link as well. This is news from 2 days ago. There is a recent, if you have your Netflix accounts, there was a new documentary movie about Anthony Bourdain, who is deceased now, who was a travel food writer. And in the documentary, it is his voice or the videos over his life where he goes through different stages, and because he was on TV, he has a lot of video clippings that have him describing and talking about things. But what they found out later is that there are portions in that documentary that are not him speaking. He is no more, but it's not him, but using his voice as sample. The machine or the artificial intelligence algorithms were used to create his voice, saying things that he had written but never said. So in his voice. And so when we're saying his voice, I'm not just talking his pitch or his loudness, but also his inflection, the stresses, the emphasis, and the overall quality of the voice as well, have all been recreated. And this was presented, at least in the media, as a bioethical dilemma, that if someone did not say something in their own voice, but you recreated it, does this become now this new tool for deep fakes? Deep fakes are videos or audios that are not true, but are recreated. And whether or not it should be used or how it could be used in a wrong way. And it's interesting for us because it is the use of recreating that level of detail in the voice so that you can simulate a person who was at one time living. So tone, cadence, and inflection, all of that was reproduced. we have also seen very recently how acoustical analysis was actually used as a very early predictor and detector for COVID. So there were screening tools much before the tests became available, and given that they used to take time and you weren't able to, pick up someone till third or fourth day after they would show their symptoms. In fact, this was an app that was started in Israel called Vocalis Check, that someone would cough, and then using the cough analysis, the sound of that cough analysis and the voice analysis, they would the machine would detect if that person had COVID or did not have COVID, with a very high rate of accuracy. So again, some of these technological changes are not just about new machines, but also fine-tuning what analyses or analysis algorithms that we currently have. This is also research that was done not only in terms of identifying COVID, but also with the mask on, or if you were, if someone was talking with over Zoom, how that voice changed, and especially that had relevance to teletherapy, which also became a big deal during this last year and a half. So especially for voice, how do you make sure that you are getting you're getting assessment done and you're recording the voice, or the patient is recording the voice that they actually have, and it's not being affected or impacted by the technology, whether it's your laptop or phone. The third thing that I also wanted to kind of highlight, which will also link a little bit with the practice for management, is the idea that a lot of these apps or technologies are not just extracting the measures, but also providing an interface between the clinician as well as the patient, or also the patient and their disorder, where they can become that could expand their awareness, expand their understanding about the disorder, as well as provide the biofeedback so that they can self-monitor or self-regulate their function. And so in addition to just the technological aspects, there has been also advancement made on understanding human behavior. What makes someone do what they do? What kind of reinforcements, what kind of feedback helps in performance or heightened performance? So there are lots of psychological theories or behavioral principles that have been infused in our practice now. So I'm going sort of overview with this, and sort of I will pinpoint one or two among them and give you some examples. But if you're interested, I'm hoping that by providing you also information from where to look for that information, you can get more details about each aspect or each type of treatment as well. So what has been a big part is not just in terms of, okay, I'm providing them feedback, or this now we're giving, which has always been, it's not a recent, it's the portability of the feedback, or the fact that it can be something that the patient has with them outside of a clinical session, that is the advance or the progress made. What is different is that our own approach to treatment has changed. One thing that all of you who are clinicians or have private practice or working in a setting are acutely aware of is the fact that you can give all kinds of directions to the patient. And it may seem as if they're understanding, and they may not be understanding, they may not even be aware that they have a voice issue. So initially we would be kind of like, I tell you when your voice is resonant, non-resonant. So someone outside of them was telling, oh, change this a little bit. You're sounding a little off here, sounding a little more breathy here. So make these adjustments. So what if I was not there? What happens for generalization? What happens for maintenance of a behavior? So that's one aspect. So that's where the continuous feedback helps. The other aspect is adherence and compliance. So let me talk a little bit about adherence. That means that I may say, let's do these things every week, every night. This is your homework. How do we make sure that they will do that? And when I say I make sure, I'm not trying to be like a school principal saying, what happens if you didn't do this kind of thing. But for most of the treatments that are physiological based, that continuity is very important. That practice is very important. And so if someone's not doing it in a systematic way, that will reduce the efficacy or effectiveness of the treatment. So the patient may feel it does not help me. So they may come 2 days and 3 days they're not there. 4th day they're back, but then again they decide not to come. And that the fact that the patient's either not following the directions or the fact that they're not regular about it is impacting your treatment, is impacting the progress you make with that treatment, is impacting whether or not the patient will improve or not. And so instead of just saying, I did my work, I explained to them, if they don't do, that's their problem. We have also looked into how can we change the approach of how we deal with disorders, and that will increase the possibility of the patients both adhering to the treatment as well as the whole program, and staying and complying with those guidelines. And so here we're talking about the fact that's persuasion. How do you persuade someone that this is effective or will be useful? There are lots of different theories and principles, and one model that has become very prominent again in our field is the trans-theoretical model, which had previously been used for things like weight loss or not quitting smoking or quitting drinking. And the same kind of principle has been adopted for our purposes as well. Why does if someone's in a weight loss program, they know they want to lose weight. Do they know that they want to lose weight? What is stopping them? Where is the point of breakdown? And it's not just, if I can repeat it 5 times, people will do it. It's more of like, what kind of information should be given at what stage to increase the chances of that adherence. And so there are now a lot of research that looks at social and cognitive factors along with the technology to look at how we can predict whether someone will adhere to the protocols, whether they'll adhere to the treatment or not. And so here are a couple of articles that Eva Van Leer has done. Eva Van Leer and Alison Behrman, their research has, and they've published quite a bit about this socio behavioral aspects of treatment, especially when we link it also with technology that can monitor or technology that can provide the feedback. So here are some apps again that, for example, This particular, it's an iOS, which is iOS is a Apple-based platform, and so an iPhone app, which also is extracting CPP, which is the substral prominence measure, and but it's not what substral peak prominence measure, but it's not what it's extracting. It's giving real-time feedback, which is very exacting. CPP is a assessment measure that is also very indicative or has high correlation with dysphonia. And so you are being very specific and sensitive to the voice disorder, but also coupling it with a user interface that allows them to monitor across different tasks and across the day, and also tracks how those changes what changes have happened when the patient is not only when they're in your session, but also in their vocal use outside of the session. Going back to some examples also of building self-efficacy. Again, these are some tools or questionnaires that I've also seen them when the patient's not feeling conscious about what they're doing or the task they're doing, or kind of rating or knowing also that how will someone not do this task because they feel it's too silly, or what will people say if I'm sitting in a corner and going me 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 me, or I'm doing a vocal trail, or I'm doing some kind of straw singing or straw trails, and it'll be so silly. So it's not, if they did those tasks, they would probably have improvement, but their own biases or reactions to that task itself is stopping them from doing it. And so both gauging that as well and using that information in your counseling, in your instructions, has been found to be quite I wouldn't want to say substantially useful in improving the adherence and effectiveness of treatments. Okay. So here are some examples of, for example, one aspect of counseling is motivational interviewing. And most motivational interviewing is, again, it's quite, there are many components to it, but the basic idea is that you find where any human behavior is broken down into 4 stages: pre-contemplation, so level of knowing, where someone doesn't even know that they need change or they want to change. So they're kind of still figuring out, is that important for them? Then their contemplation, they think they do want to make a change, but their life at this time is not, they're not ready for it. There's just too much happening. This is not a good time. I have exams. My mother-in-law's visiting. It's just too much driving. I'm very busy at work. So even though they know the value of it, it's hard to do it at that time. Third is when you are at an action where you think you're willing to, ready to take that action, but there may still be how much action, can you do it every day or not? And then the final aspect is, again, being at a place where you can reflect and carry that activity in the way that's exactly intended to be. So kind of figuring out where the person is in these stages, and figuring out based on the questions that you ask the patient. But within that also there are guidelines of, if someone is not ready for action, if they're not in the action stage, telling them very deeply on all the, you have to do task 1, task 2, task 3, task 4, that will not help. you have to get them through these stages. So that means at that point, when someone's not ready to take an action, you actually will work through, where are you? What will help you take the action? Do you need more information? Do you need more convincing? Do you think you can do it? Is it something that is achievable or not? And so sort of reflecting questions, summarizing their responses. And so there is a whole list of process that you go through that are also very specific to which stage someone is in. So you will not do something that is for stage 4 at stage 1. So again, there's a lot of information about what those stages are and examples of that. But I just wanted to kind of say that that also has been found in practice to have far more benefit in making sure that the therapy is actually effective rather than just how many patients we see in a given day. Okay. And also picking up some newer therapies or newer programs. You may have already, if you're working with clients on a regular basis, you may have worked with, in the beginning, may have worked with the facilitating approaches by Daniel Boone. And they are a whole gamut. They're very symptomatic. So that means if someone has this issue, their tone is in the back. So how do I just identify this is the problem and use a strategy that will facilitate a more forward focus. But you're kind of staying, you're being very symptomatic in your approach, and you may mix and match different approaches. You may also do trial and error and see which one works best for different clients. So it's a very less structured and more intuition, experience-based approach. In more recent times, we have become two more prominent approaches. One is physiological. So we don't just do things because a trial and error, we do it because we understand the physiology. Why would resonant voice work? What happens physiologically with resonant voice? What happens physiologically when you're doing a vocal function exercise? Understanding that what is happening to the TA muscle, what's happening to the CT muscle, what is the mouth's posture? So what kind of sound should I work on? What kind of hierarchy helps with physiological training, not just I think it should move from smallest level to a longer word that you would probably have for articulation, but it's not functional for voice. So physiological approaches, but in addition to physiological approaches, we have moved to more holistic approaches, where we're not only looking at systems in isolation, but looking at subsystems that all work together for the optimum voice, for the optimum speech. So you also are working on improving breathing. You're improving breathing, how the breath couples with the phonatory behavior, and how the phonatory behavior, a phonatory subsystem, articulates or couples with the vocal tract configuration, so that there is least strain, there is least pressure at the laryngeal level, and more work being done, or more strain higher up, or more upstream or downstream. I always get that mixed up from the larynx. So one such treatment, and I always keep a straw handy near me, is the semi-occluded voice treatment. Ingo Tidze was I was my mentor, and in fact, this was one of her early works that has now taken a whole big. It's become a whole big treatment in itself. Is using different straw lengths and straw diameters, which is based, it's not just, oh, let's work with straws, but has a very technical, and I say technical, I mean there is a whole computational basis to why these diametric changes or different flows, what do they do to the vocal tract or oral tract configuration, as well as working on the idea that you are when you use a straw of different diameters, you are making sure that the pressures are generated and distributed across the entire pathway, not localized below the glottis. And also that the overall configuration or the flow, as it's flowing through, most of the stress or the strain is at the level of the connection between the lip and the straw, and reduced at the level of the vocal folds. So you can go higher intensities, you can do pitch glides without straining your vocal folds. And you're also, here is a big thing about this whole aspect, is that you're also working not just at the laryngeal level. This is a picture from an MRI. So it's an MRI reconstruction during an actual bowel production. But what you are doing is that this area above the glottis, that is between the epiglottis, the vocal folds, and the walls, which Dr. Titsa calls epilaryngeal tube or epilarynx, monitoring more change here rather than tightening or medial compression of the vocal folds. And this, by reducing the size of this epilaryngeal tube, you match it with the vocal oral tract above it. And so there is more power exchange, there is more efficiency of the system. And so you can, especially for patients who have phonotrauma, because of hyperphonia, you see a reduction of the strain, you see that reduction of phonotraumatic behavior. So semi-occluded vocal tract, you will find a lot more of, in the more recent research, that is one technique that has become very, you'll see a lot of articles and work on that. This is also a fairly recent paper, and I don't know how well it relates to practice in India, but this is a recent paper that also over time has the standardization of what the protocol should be, especially for instrumental assessment of voice. So if you're doing a combination of endoscopy, what are the parameters, what are the tasks you test for, what do you do under continuous light, what do you do under strobe light, and what parameters you are going to be looking at for your assessment. If you are doing acoustic analysis in combination or exclusively, then what are the tasks, what are the measures, and also with recommendations for what kind of microphone to use. It's recommended that the microphone should be head held rather than handheld, so that any change in movement of the head is the microphone's following that, as well as the directionality, the type of microphone, how far should it be from the mouth. It should not be directly across because of proximity effect. There should be a 45-degree angle. And so all of those recommendations of for acoustic analysis, for endoscopic assessment, and for aerodynamic assessment. These are documented in this paper, and currently we're using these protocols. Okay, so I think I have kind of done a broad overview of what are some of the more recent approaches or foci of research in voice assessment and management. I did tell you that I'm making two big omissions. One thing that has become more prominent in our practice is cough management, chronic cough management. So we're seeing this has become part of our scope of practice, especially in acute care hospital systems. Voice scientists, voice clinicians are also looking at management of chronic cough. And so a lot of recent literature has been looking in, because it's a new area, what aspects of chronic cough are kind of how to manage and what different symptoms mean in terms of their etiology and in terms of guidelines for what needs to be done. The second I'm omitting, and I think that over time, which is telepractice, which has become a big part of our COVID years, and it's not going anywhere. So with telepractice, how do you get good data? How does the patient, how do you do your assessment, even acoustic assessment, when you're a remote location? How do you collect data? How do you give instructions? How do you provide models for correct production when you're not physically in the presence of the client, and may or may not be able to see them completely? How does our practice pattern change with that? So I have not talked about it in my talk today, but I'm open to it if you have any questions or things you want to discuss. And with that, I want to say thank you so much for your very patient listening, and I look forward to your questions.
Thank you, ma'am. Thank you for highlighting the recent advances that have taken place towards management of voice disorders. Very interesting to know where the use of artificial intelligence and the various screening tools and apps for voice therapy. It was indeed a very interesting session. Thank you very much. We have a question posted by one of the participants. Could we take them up, ma'am?
Sure, yes. So Dr. Meghashri Singh has asked if can the new screening tool using AI...
Yes.
Sorry?
Yes.
Can the new screening tool
I think
using...
it's artificial intelligence.
Yes. Using AI is artificial intelligence, voice analysis to detect COVID-19 be used with difficult to test populations, especially children and infants. I think that's absolutely possible. I do not know what this was a private company, and they probably had their own algorithm for machine learning for detecting the COVID symptoms. This was not a published article, but a media article that I presented before you. But I think if we get actual research of what algorithms that they use and what was extracted and how that process was carried out, I think machine learning is actually being used very in the research areas, not as much in our clinical population for a few things. One is to even differentially classify. So even if you could broadly classify or detect someone who has Parkinson's or someone who has ALS, and for Parkinson's, again, they have a machine learning that will help with early detection of Parkinson's. So your question was, can we use it for pediatric and infant population? And my answer is absolutely yes. Because those parameters, once we have identified how is an infant or child production or normalized production, like machines can be learned with patient population to see how a patient parameters vary. And with these AI systems and artificial learning, the machine is actually learning, actively learning. So you present initial parameters, you say this is what the final diagnosis was. You can feed multiple client information with human diagnosis, and then the machine weights. And when I say weights, it's not WAITS, it's WEIGHTS, and says weighs out what parameters are important and how to also differentially categorize or classify. I see that will be a part of our field very, very soon. Very hopeful about that. Great question.
Thank you, Dr. Samyukta.
Thank you, ma'am. That was the only question posted.
You have done a very fascinating work. I don't think many people would get that opportunity. You have demonstrated to be a role model for many of the young students. I'm sure many of them would like to follow your footsteps and do work on many of the aspects that you mentioned during your presentation. I knew that you would be giving us the update of the work that is going on voice. So that is one of the main reasons I thought of inviting you for this webinar. And of course, I'm very much happy that you're abreast with the latest information and you have been doing a wonderful job. And thank you very much. And I wish you all the best. I'm sorry we have kept you awake late in the night. So we are sure we are going to call upon you again to have some more details. At least I have found some of the things as interesting. And definitely I would be in touch with you to get that information. And thank you so much for taking part in this.
It's my privilege and honor, sir, and I will be remiss if I did not mention that my interest in voice. I have always been interested in a lot of things, but pursuing voice as my specialty and going deeper into it was fueled by you. So I'm extremely indebted to you for that, and I would like to thank you for being my voice professor, as well as fueling that curiosity and interest in the area of voice. Thank you.
Yeah, still I remember during the master's degree at Aish, you had come up with new idea for your dissertation. Still I remember that. So you have always been very curious about new things and working on that. I wish you continue on that. Thank you so much.
Thank you. And I wish everyone a very good day, and if you have any questions or anything that you would like to contact me, I think Dr. Natraj and others will have my email address as well, and I look forward to hearing from you. Feel free to reach out.
Over to Mrs. Sanjanam, please.
Yes, sir. Ma'am, on behalf of JSS Institute of Speech and Hearing, I request you to kindly accept the letter of appreciation for being the resource person in the today's webinar. Thank you very much.
Thank you. Thank you. Thank you very much, everyone.
With this, thank you, ma'am. With this, we have come to the end of the webinar series.
Thank you very much.
With this, we have come to the end. Yes, sir. Yes, sir. With this, we have come to the end of the webinar series. I thank all the participants for joining us for all the sessions of the webinar. So, to inform the participants, we have posted a feedback link in the chat box. Kindly access the feedback link and post your feedback in the respective feedback form. A certificate will be auto-generated to the email provided by you.
Finally, I would like to thank all the resource persons. We were able to get 20 resource persons from different areas, different parts of the world. And I'm happy that we have made a very impressive webinar. And of course, I also thank the participants. I wish more of them had used this opportunity to learn more about their own area. Anyhow, thank you very much. I also thank our staff, specifically Dr. Narasimha, Dr. Saransh, Mrs. Sanjana, and others who have helped me in conducting this webinar. Thank you all. Thank you. Bye.
Thank you, sir. Participants may please fill the feedback form. I request you all to provide your correct email address because a certificate will be auto-generated to the email address provided by you.